Welcome to the Motion Lab, the podcast that explores the science of movement and helps you live a stronger and healthier life.
Hello, everybody. Welcome back to the podcast. I'm here with Dr. Alex Forrester. Dr. Forrester, thanks for joining us.
Yeah.
He's one of our joint replacement specialists, mostly specializing both knee and hip replacements, correct?
Yep.
And so we wanted to do a podcast today about talking about joint replacements. Joint replacements, especially knee replacements, are becoming more prevalent, right? I think the statistics showed in 2022 it was over 1 million joint replacements were done, but by 2030, they're saying over 3 million. So as the population is aging, we're doing more joint replacements, and we're trying to find different technologies or ways to do these joint replacements to decrease the pain afterwards and increase the patient's functional capabilities, correct?
Yeah.
And so you do a specific approach called the sub-vastus knee replacement, and we just kind of wanted to talk more about that. Can you tell us a little bit about it?
Yeah. So, I'm Alex Forstrom, fellowship trained joint replacement surgeon. I specialize in hip replacements, knee replacements, and then, the complex hip and knee replacements and revisions. So that's kind of what my training's been in and what I'm passionate about. So we're talking about sub-vastus knee replacement today, which is very trendy because it's gained a ton of popularity in the last really year from what I've seen. There's been a group called the Jiffy Knee surgeons, which is a group that started out of Virginia. They started doing muscle sparing knee replacements, but they kind of branded it and have this special training for it. And so we're talking about what I do today. That's, about a model to show people, but this is a knee. Femur, tibia, fibula is a right knee. And, the traditional approach to doing a knee replacement is something called a medial parapatellar arthrotomy, which is the approach that probably 90+% of surgeons in the country use. It's this is your quadricep tendon right here, and if you can imagine, there's a muscle belly here called the vastus medialis and a muscle over here called the vastus lateralis, which are two of the 4 quadricep muscles, quad meaning 4. And so the traditional approach was to split the quadricep tendon in the medial side next to the vastus medialis, and then split down the side of the patellar tendon in order to access the knee joint. And really back in the 90s, the guy I trained with, actually, Aaron Hoffman, published an article. It was called the sub-vastus approach to knee replacement. It had been done prior to that, but not a lot published on it, which is basically a muscle sparing approach to getting into the knee. So if you can imagine, when you split the quadricep tendon, you're separating the vastus medialis from the other muscles to get into the knee. But to do a sub-vastus knee replacement, which is what the Jiffy surgeons actually do, what you're doing is you're taking the muscle belly off this septum here called the medial intermuscular septum, and you're pulling the muscle over in its entirety. So the entire quadricep muscle and all of the extensor mechanism stays intact to do a knee replacement. So it's considered a muscle sparing knee replacement because you're not actually cutting through tendon or muscle to do it. So yeah, it's the data is, there's a lot of data on it, and you can find whatever you really want to see, but there's a lot of data that says that it's improves patients' pain afterwards, improves their extensor mechanism strength, and their ability to do basic activities of daily living like climbing stairs, straight leg raises, and getting around pretty quickly. So that's something I'm passionate about doing.
Yeah, I was going to say, correct me if I'm wrong, it's been around for actually quite a long time. I mean, I feel like my whole career they've talked about the sub-vastus approach, but technically it's a little bit harder of approach, and we didn't necessarily have the best equipment for that. So because of the technical difficulty of the approach, it wasn't as popular. But now that the equipment maybe has gotten a little bit better, the technology has gotten a little bit better, it's been a little bit easier of approach. Is that correct to say, or not really?
So I'd say that training is a huge part of it.
Yeah.
So when I was in residency, I never saw a muscle sparing knee replacement. It is it's easier to do a medial parapatellar arthrotomy, and you're just straight there and you're into the knee. There's a little bit of a learning curve doing it, and I think that it's something that if you have good training in doing it, then you can safely do it. And a lot of people, for their benefit. So, it was interesting when I was a fellow, The first 6 months, we did all traditional knee replacements. And the second 6 months, we did a large portion of muscle-sparing knee replacements. And a lot of those people, they were getting their second knee done. They'd already had their first one done, say, in the first 6 months. And the thing that kind of got me most passionate and interested is that I rounded on every patient that we operated on in fellowship. And when I saw those patients, unanimously, all of them asked, why is their second knee replacement going smoother than their first one did?
Yeah.
So that's where I kind of started to buy into it.
Piece it together that by not cutting through that parapatellar or that patellar tendon or medial retinaculum, you don't have to have necessarily the healing time there. And potentially, as you said, they can have quicker recovery, quicker motion, quicker return to weight bearing. Have you noticed they've had a less, after a knee replacement, a lot of people have weakness or like their muscles don't tend to want to work as well because of pain and inflammatory response. Is that less with the sub-vastus approach?
By and large, yes.
Yeah.
So they get their motion back faster.
Nice.
And they have better strength right out of the surgery. I do a lot of these surgeries, even as same day surgeries. So they get a knee replacement and they go home that day.
Mm-hmm.
I always check on them in the recovery room, what's called PACU, or the anesthesia care unit. And they can all do, straight leg raise right after surgery, which is not something that you uniformly see after a knee replacement.
Now, correct me again, not everybody's a candidate for this. Is that correct?
Yes.
Who would be a candidate and who would not be a candidate for your practice?
So I always tell patients when we're considering doing a muscle-sparing knee replacement that they've met me, we've signed them up for surgery, and they trust me. So I hope that they trust me to do what I think's best for them as far as the approach. And very well, I can tell who is a great candidate and who is a bad candidate, but there's some gray area that's in the middle.
Mm-hmm.
Someone who's 70 with not a massive muscle belly and a standard varus or valgus arthritic knee, easy to do.
Mm-hmm.
And it's really no more challenging for me at this point than doing a traditional knee replacement. It's when you get somebody who has a BMI that's pretty elevated or a really muscular leg, stout leg, that it can be, in my opinion, almost more muscle damaging than muscle sparing.
Makes sense.
If you pick the wrong person.
Yeah.
And another is someone who has a lot of scar tissue around the knee. So if they've had 5 surgeries on their knee and it's a salvage procedure and their knee's really deformed, varus, valgus, it's not a good candidate to do a muscle sparing knee replacement on, because that scar tissue limits your ability to mobilize the tissue to be able to see what you need to see to do a knee replacement.
Mm-hmm. That makes sense. So, when we're talking about knee replacements, the implants themselves are obviously a variability. Each surgeon has their own implants that they like, but we try to control as many things as we can to allow the best outcome for patients after the surgery. And one of the things that, we can control is the approach that we use, and the muscle sparing approach hopefully improves their outcome afterwards. As far as how you put the knee replacement in, I know there's talk about anatomic knee replacements versus kinematic knee replacements. So anatomic, kind of aligning them back to a straight position. You mentioned somebody that's kind of bow-legged or knock-kneed, and we straighten them back out.
Yeah.
But there's also the thought process of let's just recreate where they were, because maybe that won't cause as many problems. That's the kinematic knee replacement, correct?
Yeah. So the two main ideologies around doing a knee replacement is mechanical alignment and kinematic alignment.
Mm-hmm.
And there's a lot of flavors that have come off of this that people talk about.
Yeah.
Personalized alignment. You can get into the weeds talking about some of that. The original way that knee replacements were first done was with something called mechanical alignment.
Mm-hmm.
And basically, if you look at a person's knee, they vary vastly. So some people have obliquity to their joint lines. So their knee may be in, their tibia may be in varus, or it may be neutral. It's almost never in valgus. It's very rare. The femur is typically in valgus, but it can be more neutral. And the original way of doing knee replacements with mechanical alignment was basically this concept where you cut the tibia perpendicular to the mechanical axis of the tibia, and you cut the femur in line that's perpendicular to the mechanical axis of the femur, which is from the center of the hip down through the center of the knee. And that has worked reasonably well. And in the right patient, whether you do mechanical or kinematic, they're likely to benefit if they have severe arthritis. And so that's kind of how it originally started. And the thought was that would limit the amount of wear that you got in the plastic insert in a knee, because it would equally load both sides. The problem with mechanical alignment is it's a one-size-fits-all approach. So the concept was that everybody gets cut mechanical alignment for the tibia, mechanical alignment for the femur, and then you stuff a polyethylene in there until it fits the knee. A new concept that's also definitely gained a lot of traction recently, and a lot of people have shifted their practices towards doing, is this concept called kinematic alignment. So there's this classification of knee replacements, which is called coronal plane alignment of the knee. So coronal plane means the alignment in this plane right here. So you can have someone who's bow-legged, you can have someone who has a neutral knee alignment, or you can have someone who's valgus. And of those people can have a neutral joint axis, a varus joint axis, or a valgus joint axis. So really, when you look at all of them, there's 9 different CPAC classifications. And the concept of kinematic alignment is that you recreate a person's CPAC. So if they, for example, a very common alignment of the knee is to have a varus hip knee angle, which means you're bow-legged, and you have a varus joint obliquity. And when people have that, their knees tend to become more bow-legged and more varus over time. If you bring that person past varus and put them in valgus, and you put their joint line in valgus, there's good data that says they're going to hate you. Because you've put them in a state that they've never existed in,
or at least not for a long time.
They never existed in that state. And so you've mistensioned their ligaments, and you've put them in a state that's not native to them. So the concept of kinematic alignment is to correct that person, but to leave them within the same CPAC classification. So if they're, so for example, whenever I do a knee replacement, I get what's called a standing alignment x-ray on everybody. So I'll get an x-ray from the hip all the way down to the ankle. A lot of times I'll have a person who has an arthritic knee, and they'll have a non-arthritic knee. And say this knee's in 15 degrees of varus, and this knee over here has no arthritis in it, but it's in 4 degrees of varus. I know that I have a goal of 4, not 0 or -4, but 4.
Try to match the opposite side.
Yeah.
Yeah.
You try to match it up.
Yeah.
And so you can measure their joint obliquity and their hip knee angle, which is their varus valgus axis, and you can try to recreate that doing kinematic alignment. I'll tell you too, so when I was in residency, some of the surgeons I worked with did mechanical alignment, some did kinematic alignment, and in fellowship I did exclusively kinematic alignment. And I'll tell you, in my experience, without a doubt, they do better. The concept is recreating their pre-arthritic anatomy. So it's not a one-size-fit-all approach, but it's a personalized knee to the patient.
Yeah. And I with the mechanical alignment, I know, throughout my career when I did that, we would have to, what we call, balance the soft tissues, right?
Exactly.
So you would put them into you take somebody that's bow-legged, you make them straight. And obviously to get bow-legged, you're going to have to stretch some ligaments out.
Yeah.
And instead of matching the ligaments that they already had, we would have to kind of open the ligaments up.
Bicrust.
That created a large inflammatory response, or created a healing response afterwards, or created more stiffness afterwards, which potentially then made the surgery more difficult for them. And now with the kinematic alignment, you don't have to, you leave the soft tissues where they're at, and you try to match where their soft tissues are at. So they, for hopefully less of that soft tissue response or inflammatory response afterwards.
Exactly.
Yeah. I think that's been a big benefit of it, is the patients, from a recovery standpoint, to have less swelling, motion comes back quicker, less pain afterwards, because we're not having to take down a bunch of the ligaments to try to match what we thought their alignment should be.
Yeah, exactly.
Yeah. And so, when we kind of move into, from a joint replacement standpoint, we also talk about kind of pain control, and pain is a difficult part. Knee replacements hurt. I'm honest with every patient. I tell them knee replacements hurt. It's a lot of pain afterwards. It's a hinge joint, only really moves in one direction. And that creates a lot of stiffness afterwards. Are there specific things you do as far as your protocol afterwards to try to help patients control the pain and get them up mobilizing quicker?
Yeah. So that's been a hot topic in knee replacements, and it's something that people have been trying to figure out for 50 years now, because you're exactly right. Knee replacement's painful surgery. If you look up what's the hardest surgeries to recover from, you see spine surgery, you see total knee replacement, like, right there with it, because it is a tough surgery. And realistically, the entire recovery process takes about a year after a knee replacement. So there's been these concepts that have come around. One is reducing opioids. And how do you do that after you have a knee replacement? Some people, after they have a knee replacement, they just want to get moving and get going right away, get on the bike and get after it. And I do think that you have to kind of tailor your approach to the patient, because, again, it's not a one size fit all for everybody.
Definitely.
But there is pretty good data that there are medicines that can help, during surgery, before surgery, and after surgery, that all aid in the recovery process. So, my protocol includes what's called multimodal analgesia. So Tylenol, anti-inflammatory, an opioid if needed, a muscle relaxer, and then there's also some things that go in beforehand too. So all of my patients get preoperative NSAIDs, Lyrica around the time of surgery, which seems to help with nerve pain, and then what's called a periarticular block, which I think is a very important part for pain control after a knee replacement. And the other things is just kind of what do you let your patients do, and how quickly do you let them do it?
Yeah.
And I'll tell you, that has kind of varied widely since I've started practice, depending on who the people are. Some people get up and move, and they come back to the 2-week visit, and they're walking great. They're not using a cane. They're not using a walker, and not having pain. They're not taking opioids. But that's not everybody.
Yeah.
And I'm not going to fool anybody by saying it is,
Definitely
because
not.
there's certain people who do struggle with pain more and swelling afterwards. And swelling is a big part of it. Ice, elevation, and really, rest for the first week. So it's not getting up and getting back on the treadmill. It's really letting a wound heal, because it's a big wound when you have a knee replacement. Even though there's only an incision on the front of the knee, you really have to think the whole knee's been operated on.
Yeah. And we talked about this before we kind of started the podcast. It's kind of shifted the mentality. Well, when I started, it was like, get them moving right away, because we know the knee replacement gets stiff and we want to prevent that stiffness. But there's also a large inflammatory response. There's a big response from the surgery itself. And then if they go out there and try to move a lot right away, it creates more inflammation, which then potentially creates more problems afterwards. So as you said, maybe actually calming them down that first week, not doing as much as they want to do, to allow that surgery response to then go down. Is that correct?
I agree. Yeah, I think that, my approach has been kind of the approach of telling patients, for the first week, I want you resting, and I want you elevating and icing, keeping the swelling down, and limiting your activity. And I think I've seen it several times where you have a really gung-ho patient who has the surgery and they want to get back and they want to start cycling on the bike right away. And they swell more, and they swell for a little longer. I think they all get to the same place in the end, but they torture themselves a little early by doing maybe
Too much
more,
too soon.
Yeah, more than they should.
Yeah. And that's hard. I mean, we obviously live in a very outdoorsy kind of athletic, community, and people want to get right back at it. And kind of the mentality for all of us is that the quicker we start getting back to our normal stuff, the quicker we're going to recover. But that's not necessarily the case, especially after a surgery.
Yeah.
And so a couple kind of quick questions I always get, at least from a knee replacement standpoint, and I'm sure you get all the time, that we can maybe address. How long does a traditional knee replacement last? That's a question that we always get. What are your thoughts on that?
So my advice that I give all patients when they ask that question is, I tell them knee replacements are like car tires. The things that are more likely to wear a knee replacement out are how much load do you put on the tires, and how hard do you drive the car. So there's a lot of data that says that younger people are more likely to have a revision, whether it's due to loosening or wear of the components. So I think that there's the two factors that you can control are what's your weight to some extent, and how active are you. So knee replacements have shifted. Originally, they were done on definitely older people in stage arthritis and no other options. And now we've gradually shifted it to younger patients who they don't have another option other than knee replacement. So, I think if you're looking for a number, I'd say the average is probably 20 plus years realistically. But there's people who will have to have a revision sooner or later than that.
Yeah. And I tell patients that all the time. I think the younger you are, the more miles you're going to put on that knee, the higher potential you have for a revision, because you're going to potentially wear the components out, the plastic out, whatever it may be quicker, like you said, from the car tire tread analogy. But we're doing knee replacements in younger patients because we're finding that they need them. Patients are wearing their knees out quicker because they're putting so much wear and tear on their knees as well. What about return to activities? What's your advice on that? I mean, we live in a ski community. We live in a hiking community. Patients probably say, when can I get back to hiking, to skiing, to doing the pickleball, doing the things I like to do? What's your traditional advice regarding that?
So I think hiking, absolutely. Skiing, absolutely. Pickleball, absolutely. After all those things are very reasonable expectations to have after a knee replacement. In training, I've heard people say, you may be playing doubles tennis, not singles tennis.
Yeah.
After a knee replacement, I don't know if that's necessarily true. I think that the activities that I counsel patients on, they want to know is like, can you run after you have a knee replacement? Well, I mean, there's a lot of people out there who say you can do whatever you want after you have a knee replacement. Do I think it's wise to run after you have a knee replacement, though? No, I don't. And honestly, there's not many people who are coming in to look for a knee replacement. So they don't have that expectation to get back to that. But can you, if it's raining and you're in the parking lot, can you run into the grocery store? Absolutely.
Yeah.
But should you go run half marathon? I don't think that's realistic after having a knee replacement. A hip, that's a different story.
What about skiing?
Skiing for sure. Yeah. No, I did my training in Salt Lake City, and half the patients we did joint replacements on and knee replacements on skied, and uniformly, assuming they could ski before they got a knee replacement, we got them back to doing that.
Yeah. I tell everybody, like, if you have to catch the bus or you're being chased by a dog, like, yes, you can run, but it goes back to the concept of the running puts more pounding on the knee replacement, which potentially increases the risk of wearing it out sooner. So let's not, go train for 5Ks or marathons on the knee replacement. And there's a lot of professional athletes that have gotten joint replacements, but have had to add revisions pretty quickly because they put too many miles on it. So there's definitely some aspect to that. Well, thank you very much for joining us today. If people want to kind of explore this muscle sparing approach as far as a knee replacement, how would they get a hold of you? What's the best way to get a hold of your practice?
I would say call the clinic, 719-632-7669, and ask for a consultation with Dr. Forrester.
Excellent. Anything else you want to add?
No, I think it was a great podcast. Thanks for having me.
Excellent. Thank you very much. We'll see you guys at the next episode.